Hey, I'd like to begin by introducing myself, and I'm Kishore Mulpuri, and I'm current president of Canadian Orthopaedic Association. It gives me great pleasure to chair this and moderate this session with my colleague, Dr. Jeremy Hall from Ontario. It's a real pleasure to see our different societies here represented to talk about some challenges that we have and also possible opportunities we have. In my world, every challenge is an opportunity. So I think that's what we have here, our leaders of our respective groups and societies that are here to talk about those. Before I begin, I would like to acknowledge that I'm speaking to you from unceded traditional ancestral territories of Musqueam, Squamish, and Tsleil-Waututh people. Furthermore, this acknowledgement and gratitude and respect extends to the Indigenous communities from where you're joining today. And I'd like to really acknowledge this amazing work that our societies and your societies have come together today. And what we have here is representing Canadian Nurses Association of CONA, Operating Room Nurses Association of Canada, and we also have the ORNAC's secretary represented here. And then we have president of the Saskatoon Orthopaedic Association, president of Alberta Orthopaedic Association, and the current president of British Columbia Orthopaedic Association. So you can see, and people are bringing a lot of wisdom from different groups and different parts of Canada. So without further ado, what I'd like to do is get my co-moderator and also a panelist to introduce themselves. I'm going to call out their names, and I want them to sort of say who they are, who they're representing, and then after that we will start, I think, our discussion about the current situation we're in, the opportunities we have. Jeremy.
Great. Thanks so much for having me this evening. I am the now just past president of the Ontario Orthopaedic Association, and pretty excited to be here this evening. I think that this is a great event. I think that we're going to learn a lot.
Great. Maureen?
Hi, everybody. I'm Maureen Slyhavy. I'm the board president for the Canadian Orthopaedic Nurses Association. We have members, of course, across the country, and I personally live outside of Ottawa.
Thank you. Sharon?
Hi, everyone. I'm Sharon Hollett, and I am the current president for ORNAC, which is the Operating Room Nurses Association of Canada, and I am coming to you from New Brunswick.
Fantastic. Jen?
Hi, everyone. I'm Jen Sutton, and I am the current secretary for the OR Nurses Association of Canada, and I'm coming to you from rainy Newfoundland.
Fantastic. Alan?
Good evening, everyone. I'm Alan Wu. I'm the president of the Saskatchewan Orthopaedic Association, and I'm here in Saskatoon. So thanks for having me.
Great. Alistair?
Still muted. Hi, I'm Alistair Younger. I'm in Vancouver, BC. I am currently practicing at St. Paul's Hospital, and I guess representing the other coast, we've got coast-to-coast representation. I'm the BCOA president for the last 5 years, and have obviously been working in British Columbia through the whole COVID epidemic and listening to the various concerns from the hospitals across the province.
Yeah, no, that's great. So as you can see, as Alistair rightly said, coast to coast, and people with amazing amount of experience and backgrounds that have joined here, representing various different groups and societies. So I'm really looking forward to our discussion and our conversation this afternoon. So what I'd like to ask the panel is really two important questions that we could go around the table and discussing that. And then in the end, we will take any questions that we have from the floor that will come up. And we have another panelist of ours that's going to join now, and that truly represents now 6 provinces. Andre, do you want to
Hi, how are
introduce?
you guys? Hello.
Hi, Andre. Do you want to introduce yourself?
Hi there. I'm Andre Manolescu. I'm a spine surgeon and I'm the president of Alberta Orthopaedic Society. So by virtue of that, I'm joining the meeting today.
Okay. So, our first question that we're going to ask our panelists so that we can, we can sort of have some discussion started with that. So, which is, what is the current status of, I think, the pandemic, its impact on the work that you or your members are providing? Either you could reflect on from your society's perspective, also probably for your own setting where you're in and where you're working. So Sharon, we'll start with you.
Okay, so as I said, I'm currently coming to you from New Brunswick, so that would be where my experience is from. I am a perioperative registered nurse, and I've been working in the operating room now for over 20 years. I think the biggest thing that I've noticed through the pandemic for my area is how much the pandemic has limited our access to timely care. So our orthopedic patients obviously are not getting in to have their surgeries in a timely manner. And I'm talking specifically about the ones who are, scheduled for joint surgery. Their quality of life has decreased, and it's just been it feels like here it's been constant battle trying to get patients in. I know that we have a very thorough wait list that is well managed here in the province, but it's just the access to OR time to be able to get in and to get the surgeries done. So yeah, I think that's probably the biggest part of it. The other part is when you talk about nursing shortages would be the impact of the pandemic. So many of our staff members have had to, just from being out in the community and just regular part of life are, have had to self-isolate in the past. They've come into contact with someone who has COVID or what have you. So that's specialized skilled workforce of nurses that we have here is definitely decreased.
Great. Can you hear me? Yeah. And that's something that, we keep hearing a lot. And, that the stat that I've heard somewhere is by 2030, we expect somewhere between 18 million to 20 million shortage of healthcare workers of different types by that time. If the projections are to go the way they're going with the current training trends, I think that you bring up a really good point in terms of shortages that we have. And that will continue to be the case. And in fact, if anything, that'll keep increasing for different workforces that we work with, different healthcare colleagues or partners that we all work with. So Jen, what about from your perspective? What's the current situation now where you work or from your society's perspective?
Hi, so like Sharon, I am a perioperative registered nurse, and I actually have an administrative role in the operating room here in St. John's, Newfoundland. And I was actually also an enhanced recovery after surgery coordinator for many years. So in Newfoundland, our biggest issue was really mainly focused around the shutdowns. When we started the shutdowns here, there was very limited access to any elective procedure at all. And, so a lot of our orthopedic surgeries were completely just not even booked. So we went months where we didn't do anything electively whatsoever because, we had such a small amount of healthcare facilities in our province that we didn't want to become overrun with COVID patients in our hospitals. So the access to care has been completely dismal. And from the other side and the other perspective on that is we have bed issues now at this point. So bed flow has been a major problem. What we found since COVID is it seemed like patients didn't have access to any type of care in the community. So by the time they made it to the healthcare facilities, they were exceptionally unwell. So they spent more time in the hospital. So that obviously then limits our access to surgical beds. So now that we're on the downswing and we really didn't have an outbreak in Newfoundland, we really still can't do much electively because we don't have access into our own surgical beds because they're filled with like exceptionally sick medicine patients. So we're finding, you know, on a day-to-day basis, it's a struggle just to get anything that would be considered elective done. If you're not a trauma, it's very difficult to get anything done here in the province right now.
Yeah, which is a challenge again. I think we all go through different phases facing these shortages, and we were at Children's Hospital here. We were immune for except for the first few months for a long time till our hospital decided to go with a Cerner implementation at the same time. So we have slowed down now, not because of COVID, but with other priorities that the hospitals have taken on during this time. So I think everybody's perspective and situation they're in is slightly different. Maureen?
So in my position, I actually am manager of the rapid access clinics in our region. And so we had a really, really good setup pre-COVID. Our wait times were excellent, from assessment to meeting a surgeon to having surgery, and that kind of all blew up. Same as Jen and Sharon, we're talking about challenges with staffing. Staff is burned out. Anybody that was close to retirement is going. It's very difficult to recruit staff. In Ottawa, we're all recruiting from the same pool of people, and so some people are seeing, oh, I can get a full-time job if I go over here, or if they want a part-time job, they can pick and choose where they can go. Our wait times right now are, like the other said, very, very long, and patients are becoming really upset. At the beginning of COVID, it was, okay, dear, I understand it's COVID, and now they're calling and they're irate because their surgery is going to be 6, 8, 12, 18 months from now, and they're not very happy. The other issue is we've got a lot of same-day discharge for total joint replacements. So anybody who's healthy and young will get done sooner, and the people that have comorbids that need to stay in the hospital, their wait time is being extended because they're not able to be done same day.
Yeah, no, some real challenges there, I think. Yeah, Alan, now we're switching gears to hearing perspectives of our surgeon colleagues from across the country.
Thank you. I'm an orthopedic spine surgeon and arthroplasty surgeon, and what we've experienced obviously in Saskatchewan, we were hit pretty hard with this fourth wave. As you heard, the point where we had to send 20-some patients out of our province to ICUs in Ontario. And so since mid-September, our OR elective cases have been significantly curtailed. Despite that, we were still trying to manage what we call urgent 6-week patients. And so there was some patient flow during this time, but certainly not to the same capacity as what we had before. In preparation for this meeting, I reached out to some of my nursing colleagues, the nurse manager in ORs, and some of our grassroots nurses, and try to ask them, what do you think it's going to take to get us out of this situation? Our wait list for joints has gone astronomically. And the answers were all over the map. It was quite interesting. There was generational differences. There were nurses who were towards the end of the career. There were nurses who were at the start of the career. Different opinions as to how we can ramp things up. I think we all have to agree that we can probably get back to pre-COVID levels reasonably well. We have enough staff. We had the expectations. It's beyond that. It's how are we going to get to that backlog, and what is that time frame going to be? Are we looking at a 2-year wait list to get to back to our pre-COVID wait times, or are we going to be very aggressive and say the next 6 months, once we return, we're going to try to plow through the numbers and work through it? And as our nursing colleagues have said, people are experiencing burnout. They don't want to come back. Are we going to restrict their holiday times? And that's where I think what we're lacking, at least in our province, is that type of plan. I asked many nurses, is it money? Is it just money that's important? Paying overtime? And certainly some said, yeah, I would do that if the money was good. And then there's many nurses who said, no, what? I don't care about the money. I want some quality of life. I want some free time. I want a summer holiday. So I think that's the challenges that certainly our nursing colleagues will face, probably more than our physician colleagues. I think our physician colleagues are willing to work and are able to work, obviously different funding models, but it's the nursing staff that I think is at risk, at least in our institution. What the other challenges is our variation between our hospitals. We have hospitals that are predominantly elective type based cases. We have hospitals that are predominantly trauma based. And so that mix of nursing staff, obviously the trauma, tertiary, quaternary care staff are going to be burnt out sooner than those who do predominantly elective cases. So, we're going to rob Peter to pay Paul to some degree. We have, I talked to our nurse manager today, we have, I think, 5 nursing students who are doing the perioperative training course in our institution. So that's basically 1 per site. Obviously, that's not going to make a dent in our human resource needs. How does the ORNAC and CONA ramp up that training program to meet the demands for the next 2 years? So, I look forward to this discussion. It's going to be a big challenge for us for the next 2 to 3, 5, 10 years.
Alan, you make some good points, and I'd like to hear our other surgeon colleagues and circle back with Sharon, Jen, and Maureen, so that just their thinking when we come back is some things would be what we're hearing. What does it take when we get ramp up to get our colleagues on the nursing side, if the surgeons are ready to go? What does it take to build capacity there? And I agree with Alan, it's not something you can do overnight. As much as everybody thinks that you pay somebody more that they would stay and do it, that's not the solution. Solutions need to be that there's enough capacity in the system for these kind of surges when the needs come up. But I'd be interested in your thoughts, and we'll come back to that once we hear from the other surgeons. Alistair.
Hi there. I thought there was an excellent summary. I can't remember exactly who did it, whether it was Jen or Sharon, but it was really nice summary. My wife is an OR manager. She was working at St. Paul's and now is the OR manager at Vancouver General. Both hospitals are working at under capacity. And so it's the entire chain. And one of the challenges in both hospitals has been recovery room and bed availability. And obviously, as the COVID patients come in, the bed availability goes down, it backlogs into recovery, and then it backlogs to the OR. Somehow we have to work out how we change this. These are problems that existed pre-COVID. They're just exacerbated by it. I'm sure everyone's aware of the NHS's terminology. And in the United Kingdom, every fall, they talk about the press or the push on beds for influenza. Now we're going to have a push on beds for influenza and COVID. With regard to what's happening in British Columbia, the access to orthopedic care is variable depending on the hospital, and it can be almost normal. For example, my hospital, despite our relative, slightly down in OR numbers, has been more robust, I guess, than some others. Nanaimo, for example, on the island, you wouldn't think they would be at high risk, but they took a lot of normal Northern Health patients, and their elective ORs have been shut down essentially for about 3 months. Kamloops is completely shut down, and I think is just beginning to start up again. So a lot of problems in interior health. The Northern Health in rural British Columbia was relatively well preserved in the first, second, and third waves, and has been really impacted in this most recent wave. It's a constantly moving target. There is frustration amongst the surgeons. Frustration largely about communication and inconsistent communication, and a fair amount of anger that the truth is not being told. Whether that's going to be helpful or not is another question, because it may not help those of us that are trying to work on access to care. I think one of the challenges I've seen too is it's hard to get representation. So the way that we're supposed to communicate with our hospitals and with our regions and with the health ministry is through the various physician organizations that we have. And I'm not sure how engaged, for example, the doctors of BC have been in understanding and communicating the issues. When COVID first hit, I asked to track the billings of all the subspecialty areas and see what was happening, and that would be a relatively good surrogate as to access to care. And after 2 months, we were down basically 30%. But through the year, we ended up, at least in orthopedics, about 2% down. So, that's, I think, a bit of a reassuring statistic. The other thing that was available was sort of a rescue salary in case people's billings went down so far that they may not be able to operate their offices. And if that started to happen, then we'd really be in trouble. But nobody's requested that rescue salary from orthopedics for fee-for-service physicians. So there's a number of things that have been put out there to help and maintain access to care. Going forward, I think we have to think how we strategize this, and that's a difficult question. So anyway, impact has been similar, I think, in BC and in some hospitals, better in others than the rest of Canada. And how it's going to play out in the next little while is, I think, largely unknown.
That's great. Looks like Andre has just stepped out and is, oh, you're there. Okay, so any thoughts from Alberta?
Pretty much the same thing as in the other provinces. Across the board, in most of the cities in Alberta, the biggest issues were the OR nurses deployment in different other areas, primarily to ICU. And that correlated with a great level of dissatisfaction coming from the OR nurses, because they were supposed to get trained and work as ICU nurses, but in vast majority, what they did, they were more like nursing assistants. So they weren't allowed to actually work as I don't know, equal players in ICU. However, a silver lining from that is that maybe that's the solution for the next possible surge, to look into maybe training more nursing assistants that can help out in the critical area. The other thing that impacted negatively our ability to do elective surgeries was the cannibalization of the recovery rooms in smaller hospitals. So the ICU expanded into the recovery room, and practically most of the ORs who had to give up the recovery room, they created recovery rooms in some of the OR rooms that were not used, obviously with less ability to accommodate patients. The other thing that happened in Alberta, similar to BC, there's quite a bit of variation between different hospitals. I practice in 2 zones, and for example, in North Zone, one of the hospitals that I work with wasn't too affected and was able to bounce back fairly quickly. In Edmonton, on the other hand, it took way longer. The response to or return to normal was way more sluggish than in other places. Another compounding factor on our inability to perform orthopedic elective surgeries was that the lack of anesthesia in Alberta. We have a huge problem with anesthesiologists. It's very hard to, there's a huge deficit in anesthesiologists pretty much across the province. So yeah, these are most of the things that, nothing new, but it's kind of the common denominator of what we had to face.
Thank you, Andre. Jeremy, any thoughts, comments from you? Any follow-up questions to our panel or anything from the floor?
Yeah, so there are a couple of comments that came up in the chat, particularly dealing with trying to offload the hospitals in terms of long-term care. I think that as it's been a problem for a long time, that the relative kind of brittle and inflexible nature of our healthcare system, especially in Ontario, but probably across the country, really has been highlighted through the COVID pandemic, because I really feel that there's no scalability in our healthcare, right? We're operating at 105% at all times. And then you run into a problem like a bad flu season or something even worse like COVID, and you really find what the limitations are, and then essentially exceed those limitations very quickly with no opportunity to offload long-term care patients or manage really sick long-term care patients. The inpatient kind of load quickly overcomes what our capacity is, despite the fact 15, 20 years ago, we had triple the capacity within these hospitals for beds, and they've been limited as a result of funding and other reasons and changes in medical delivery. So as I said, the comments in the chat, both in PEI in Ontario, really showing that that bottleneck of transitioning patients from hospital to long-term care, especially with the challenges that we had through COVID with long-term care, and the fact that I think as we go forward, some of the dream proposals should really be to have a healthcare system that allows that scalability with seasonal flus or with more severe pandemics like we've got now, and a plan in place to try to facilitate that care without completely, removing care from the kind of restorative procedures that we tend to do in orthopedics. I think that's something that really needs to be evaluated going forward. I got an unending list of possibilities that we can discuss, but I think I'll probably hand off back to you.
So that's great, Jeremy. And so I think a follow-up from what Alan and the surgeons have pointed out. So this is where we'll start with Sharon, and then we'll go to Jen and Maureen, is if we were to ramp up, and I know that puts a lot of strain and stress on people that are already feeling like they're overworked and they've not had a break. And a lot of people have made a lot of personal sacrifices to come back and stay long hours and work. How do we manage that if there's capacity given in the system to do more surgery? And that's another comment I'd come back to our surgeons' comment about whether they would call what they do as elective surgery or restorative or life-altering surgery. And honestly, I'm an orthopedic surgeon. I would say orthopedic surgery is way beyond elective. And I can tell you, I personally, my surgery got canceled on the day off, and I had to wait a whole 6 months to have mine done. And it is not elective when you're waiting those 6 months. And it is a life-altering, a restorative for people that have waited in pain to have their surgery done. So Sharon, so how, if we come back and there's a magic wand and they come back and say it is now $50 million, look, in a hospital, you can start doing now, 18-hour OR days. How do we start having this conversation with our partners? We can't do it without nursing colleagues, and the expertise of that just doesn't happen just because a surgeon now has decided to stay on an extra 8 hours to do that case. So, how do we deal with those kind of situations as surgeons where, we're in a kind of a lockdown mode and suddenly there is an opportunity to ramp up, and how do we deal with those?
That's a great question. And I know, personally, when I'm interviewing patients, when I'm bringing them in, they are so happy to be there. They're just like, I'm finally getting my knee done, my hip done, whatever it is, I can get back to a normal life. So I think the biggest thing, if you have lots of money, obviously, you're going to hire people. I mean, one of the points made earlier was, money is nice, and yeah, that's definitely. But I think that you're kind of getting into a good look at skill mix here. So, you've got your different types of nurses. You've got your registered nurses who are able to handle anything, like in the operating room. You can scrub, circulate. You've got that clinical background that if something goes on with a patient, then you can step up to the plate. And help with that for sure. It's that thinking ahead piece, like if things are going wrong or if you notice something on a patient assessment, it gets noticed earlier, followed up earlier, and hopefully you can get your patient in the OR sooner. But the other thing is being quite a team player. So, I mean, you've got also across Canada, they're called licensed practical nurses, registered practical nurses, what have you. They are nurses as well. Different training, different education, but we do work together as a team. So it's having a good, strong team there that can see the value of each other's skills. So, I mean, that's when you're coming back to your managers and that type of thing who are working on that human resource piece. So, and I mean, no conversation would be complete without mentioning attendants, like operating room attendants or assistants, whatever you want to have there. And they do also have their place within the OR, but they are more task driven. So if you can have them in with the mix of nurses, and the nurses have the ability to say, okay, we need this, we need that, and these people know where to find this equipment, they know where to look, they know, you know, if they're directed on how to open certain things, they can open it for us, that type of thing. So it's really, you're looking at the skill mix, you know, if you match the person to the job, well, then the job gets done. So I think that's kind of the biggest thing that stood out to me here. The other thing I'll just address is that when it comes to educating nurses, ORNAC necessarily is not, that's not something that we do. We provide education for nurses. It's part of our mandate is to work in regards to research, educational opportunities, our own webinars. We put forth our own standards of practice. So that's a big piece, but it's up to the licensing and within each province, like how that works. The universities, the technical colleges, what have you, those are the ones who are doing the training. So if you're getting into making more seats available there, reaching out to the young people coming out of high school or what have you, and working that piece to get more people interested in the profession. And if they see value in the profession, then they'll come. You'll have nurses.
Great. I mean, I really like some of what I've heard, Sharon. I think these are the ideas that I think we should pull together and work together in advocating for those. So, Jen, any comments on anything to add from what Sharon said?
Yeah, so I agree with Sharon with regards to specialty training. So one of the biggest things, if you have funding and you have money, orientating an OR nurse is not like orientating a nurse in a lot of other areas. It takes at least 20 weeks, and that's the bare minimum to train an operating room nurse. And that means they can kind of just go in and do the bare minimum of what they know how to do. So the number one thing is, you know, really providing good comprehensive orientations and training for our staff. And if you have unlimited funding, then that's not really our big issue. One of the other things too is really job matching. So one of the things that we are limited by here in my province is most of our hiring is based upon seniority, and it's not based upon your either technical skills or your actual want to be in an operating room. So if we don't, you know, have the right people doing the right job, then obviously we're going to have an issue. And that's what we find. We spend all this time and money training people who after 20 weeks say, OR nursing is not for me. So then they leave and take jobs elsewhere. And that has been a consistent problem within our province, that we're really limited by who we can hire based upon collective agreements. And I mean, that has its place as well. So, you know, I won't get into that discussion, but that's one of the things that we really need to put a big focus on. I think we need to lobby, like, you know, our own bodies. We need to lobby provincially. We need to lobby federally for these patients. Like you said, Kishore, we all know that orthopedic surgery is not elective. I have patients that come to my operating room every day that are in tears, that can't feed their family because they can't go to work. Because their knee, hip, back is so bad, and we have negatively impacted their lives and their ability to actually provide for their families by not providing access to this care. So I think that voice really needs to be told very strongly. We fought for 18 months during the first kind of wave of the pandemic, second wave, to say, like, these patients are waiting and waiting and waiting, and we've canceled them 3 times, and they've changed their lives and, you know, organized themselves to come in to have a procedure that now now they're sitting in my waiting area, and now I have to cancel them because either there's not a bed or something more urgent comes in through the door. So we need to have a focus on making sure that that voice gets heard. And then, from my ERS perspective, pre-optimization of our patients is also a big issue, and it's a big problem here in Newfoundland. We have a very high rate of patients with diabetes. We have a very high rate of patients with OSA. Those patients come to my operating room, they get seen in the surgical daycare area. And there's a lot of times when they get canceled because either the blood sugars are so high, we're afraid of surgical site infection post-op, or their sleep apnea is so bad, or they didn't bring their CPAP machine, or they've never been tested, or, we have no one to sit with them now after they've had anesthesia and we have no other option but to do it. So, pre-optimization is a big piece that I think we need to put a big focus on out in the public, number one, but in education for sure. Same day surgery is a great idea, but the patient population in Newfoundland is has quite a high rate of comorbidities, and it's not going to work for a lot of our patient population, which is unfortunate. We are trying, and it's one of the things that we've started to work on to try to do that, but it's very, very difficult. So I think if we start focusing on really like retention of nurses, recruiting of our specialty nurses, and keeping them where they want to be, so we got to make them happy.
I really appreciate your comments, and I think there are several things that you mentioned that I'm going to ask Jeremy and Alistair that I know that I've done some work on to make some follow-up comments on that. Maureen?
So I don't think that this situation is something that we can cure overnight, even if we have $50 billion to do it. I think this is something that we need to look long-term at. And the problem with ramping up ORs, we did it in our area, and then what happened is there was operating 7 days a week, and nursing staff got burnt out, and they didn't get their vacations last summer, and it was terrible. And so I think that we have to start looking long term. I agree with Sharon and Jen on their comments. I think that we should be pressing the government to treat nursing and physiotherapy like the military, where we pay for your education and in return you owe us X number of years. And if you don't do it, you pay them back, that kind of thing. But that's like that's a 4-year kind of solution. I think that we have to keep the staff we have, and that means that they need to have vacation and they need to have good pay. And I would also say that they need to be members of our organizations, because we provide education for staff, continuing education, and there should be a push as well by us as a collective to senior management in hospitals to provide memberships in these groups for nurses as kind of a perk, of the job. I really think, and somebody has just written about patients, I think we need to involve patients in our campaigns. They should be part of appealing to governments to get more resources, or what we need to decrease wait times. I've always found it really effective to appeal to patients. And then I think we as organizations, or as this group, should be advocating to meet with members of parliament in our own areas and the ministers of health for both provinces and federal. So that's kind of my long-term solutions.
Great, Maureen. I really appreciate, I think, all of your insight into some possible challenges and maybe some possible solutions. And I just want to look at some questions from the floor. And, one of the ones that came up, and I'd be interested in Jeremy and Alistair's thoughts on this, is to really, one of the things is there a province that's done well, or a group that's done well in trying to advocate for some of the challenges that we're talking about? So Jeremy, I'll start with you, then I'll go to Alistair about maybe a fast track care and what that is and what you've done. Now, looking at this panel, should we in future, if you do one of these, take our colleagues that we are seeing, our nursing colleagues, on those campaigns with us and come up with some common strategies?
Yeah, I think that's during the pandemic, we had the luxury of sort of a crossover with a plan put forward by Mobilize Canada called the Fast Track Care Campaign, which I mean, it was multifaceted, but what it really facilitated is some direct lobbying with the Ministry of Health and Government. And so as a result, we had a number of meetings with our Minister of Health's teams to discuss the challenges that we were having in orthopedics, both prior to the pandemic, but during the pandemic. And at the same time was directed, it was specifically directed at our patients and giving the orthopedic surgeons of Ontario an opportunity to direct their patients that were concerned about their care to a website which would help them create a letter that they could send to their MPPs. It had opportunities and resources that they could access to try to facilitate their own care. And so there were thousands of hits on the website and thousands of letters that were sent to MPPs as a result. I really do think that it had a huge impact on the response that we had in Ontario. I think that direct messaging with the ministry and with our MPPs did go a long way in helping to try to improve the access of our patients to the operating room. I think that it didn't at all, at least had some impact on some of the policies that were created during the pandemic to increase funding towards orthopedic restorative procedures, increase the funding for our quality-based procedures to try to facilitate the care and interest of hospitals in trying to manage our orthopedic patients. So personally, I think it went great. I think it was a huge advantage and the timing was perfect. I mean, it couldn't have come at a better time for us in Ontario. I really hope that they continue with that campaign. I know that they were looking at moving it to other provinces and giving other provinces an opportunity to do the same as we did in Ontario. Huge advantage for us and for our patients.
Alistair, since you've sort of led the Fast Track Care campaign here in BC, so any reflections on building those bridges, momentum, advocacy, and what were you able to achieve with that?
Well, yes. So the fast track care is a really an excellent way of patients being able to access their MLA. And so I just sort of mentioned the in the chat about encouraging surgeons and patients to continue to use the fast track care platform. The hardest thing for a patient, I know we all sort of see them and they come in and they're upset and they have impact on their life. Time and time again, I've heard one of the most effective ways that they can do to change the resource and the environment that we're working in and their access to care is to contact their MLA primarily and their MP secondarily. And Kelly Leach told us that when at the COA many years ago, and we keep being reminded of that. The problem is for a patient to just go out and do that on their own. They need assistance, and if they go to the Fast Track Care website, then they just have to put their postal code in, and it will link them up with their MLA. They can write personal comments, but gives them a form letter that will allow them to then reach out to their MLA, and that has had a huge impact. It then makes the MLAs and then the health ministry aware of their plight. And to me, the way forward is to continue that, because it's not only the health ministry that we have to keep engaged in the plight of our patients and the need for nursing care to look after them. It's also our hospitals, our managers, and everyone that has some influence on whether or not those orthopedic patients get access to the operating room, including our surgical business committees. The more we make this important, the more we make people aware of the suffering of patients, the harder it is for people to ignore it. And so to me, the Fast Track Care was critical on this and really helped us communicate that. And it's really the first effective thing that I've seen in that. we tried to do our own BCOA one a couple of years ago, and again, it's without the organization, without the support and the combined effort, it's very difficult to do it. And so my thought is, going forward, we need to continue with this advocacy, and more the thought I have is, how do we actually achieve that? We can obviously use fast track care, but is there other ways that we can club together to help our patients communicate their plight to the people who can control whether or not they get the access to the operating room?
Fantastic. Thanks, Alistair. So just to close up on the government relations topic, COA is planning a Hill Week, and our CEO and Chelsea, who is our manager of strategic initiatives, and yes, our CEO Cynthia, working on a plan, and strength in numbers is great. So we will reach out to your respective societies to see if you would like to join the efforts. And I think Sharon or Maureen mentioned about joining membership, and I know there's a lot of people that are on the webinar, both members and non-members of our respective societies. So my plea to, whether you're a nurse or if you're an orthopedic surgeon, you're a non-member, you're listening to this webinar, please do join your respective societies. Yeah, there's huge strength in numbers, and we need you. We need your support in these tough times, that we stay together, we work together. So from COA, we were definitely going to be doing a national advocacy at a federal level within the coming months. And we will be stressing this point. This is not elective surgery we're talking about. It's life-altering, it's restorative surgery. It is not elective. And that definitely is the message that needs to go. So I'll probably ask first a bit of a controversial question, but but we should go around the panel discussing. So I'll start with the surgeons for a bit of provocation, but I would like to hear the comments from our nurses. One of the things that come about is, if you worked in different settings, you have scrub techs and other people that provide some of the nursing OR nurses that provide here. So Alan, have you had any experience working with alternate professions? I mean, there are people that are provided care.
Yeah, no, in Saskatchewan, we're limited to strictly LPNs, RNs as part of the surgical team. So we don't have any experience with, we had a couple of RN first assists, but we have family doctors who do a lot of that. So they're not necessarily needed in that capacity. And plus they would be taken away from the nursing duties that would be more traditional. But we don't have any assistance with physician assistants, scrub techs, anything like that. And I wonder if that's something that we can pursue, at least in the short term, or is that training time frame too long? As someone said earlier, 20 weeks is minimum for training, even from an RN or LPN. So someone who has no medical experience whatsoever, I would assume that can be a bit more prolonged. So 20 weeks is what, 6 months, 7 months? I mean, that's not really going to serve our patients' needs very well in the short term. So I have no experience with that. I think it's something we can pursue in the long term, but again, the next 6 months is what we're challenged with.
Yeah. Any of the other surgeons that have had an opportunity in any of your trainings, either during your fellowships and elsewhere, you worked with, any others other than the nursing staff that we have in Canada for scrubbing?
Kishore, I've worked in the United Kingdom. I've worked in the US, or my fellowships and staff, and here, and I've not had much experience with really anyone else. And the nursing staff remain the core of this, plus or minus LPNs. I think our job is to do the ask. The hiring and the maintenance of nursing staff is an incredibly sophisticated task, and that's one thing I've learned with my wife being, an OR supervisor, an OR manager. And our job is to say, this is what we need, and we really need to let the managers get on with the job of saying, okay, how do we provide? Because all of these things that came up, like union relationships, the bargaining, all this stuff is an incredibly complex process, from what I can understand. And there's no easy solution, and we need the experts in that to provide the solution. Our job as surgeons and as patients is to do the ask and let everyone else that knows better provide the solution.
Great. One of the comments that came is, non-nursing OR assist is a step backward. And I would say, having worked in 3 different continents, and I can't think of working with anyone other than a nurse, and they, bring a very different skill set than that I have, that makes that experience very different. So I agree with the comment. I think that so Sharon, we're going to go around the table now. Any last thoughts, any reflection on anything that you've heard? And if you had a magic wand and we could do something, what are the things that you think as a follow-up to a conversation that I think we should meet again or discuss?
I think I agree with a lot of what Alistair said when it comes to the complexity of hiring nurses. There is a lot to it. Across Canada, nurses are regulated by province. So there's quite a system in place to ensure that everyone has the required qualifications. It's not, a nurse hired in New Brunswick would have to be registered in BC before she or he could work there. So there's a piece to that. And I find that nurses really bring a lot of value to the operating room. And I'm talking particularly when you get into those sticky situations. You want someone who has that background knowledge, who knows that, okay, this just happened, and they notice what it is and they can say, okay, we're going to need this now. So your nurses who are seasoned and have worked in the OR for quite some time are very familiar with the needs of their patients and are able to rise to the challenge. But I do think that there is definitely conversation that could happen around supportive roles for the operating room. So, I mean, if you're looking along the lines of that task-driven workforce where you can somehow have an OR attendant that can pick up whatever task needs to be done. So quicker turnovers in your rooms, if you have someone who could help with the cleaning, if you have someone who can bring case carts in, it's all that task things that frees up the nurses to do the work of assessing the patient or finding that missing piece of instrumentation. So yeah, that's the biggest part for me. The other part I'll say is that orthopedic instrumentation is highly technical. It's very different. We all know what happens if you're missing one critical piece from a set. It's not good. And there's a lot to that. The nurses are educated so that they can look at comprehensively at the sets, and very often with some help from the vendor of the set, the people who are, our company reps who are in the OR with us, and can say, okay, well, we're missing this piece. Well, maybe we could substitute with this, or we know that this particular tray has the equipment that we need. So a lot of that goes on behind the scenes before the surgeon comes in the room. So there's a lot of thought that goes into that, and practice and work to make sure that everything is there that needs to be there. So yeah, I think it's been a great opportunity to speak as part of this webinar, and I know that ORNAC is certainly open to any other thoughts or ideas for collaboration that COA has to offer.
Great. Jen?
Speaking from an administrative role, I am a manager here of an operating room as well, in the main trauma center for the province. And I think our biggest focus, if you're looking at access to care sooner rather than later, our biggest focus is retaining the people that we have, and there are very highly qualified, highly trained people. I think it's making sure that we can offer them time off, but it's also looking at innovative ways to provide access to care. So some of our initiatives right now are looking at, do we do longer stay lates? Do we have people stay for an extra 2 hours a day to try to get that extra case done? How do we book our same day admissions out with our outpatient procedures? And what does that look like on a day-to-day basis, so that the patients are actually getting the care and actually getting their surgeries, and they're not canceled day of because there's no way to actually get through it. So I think that we need to start looking at those types of things. I mean, we've tried to run elective lists on Saturdays. It didn't work. No beds, didn't work. We tried, to run 10, 12, 13, 14-hour days. There's pros and cons to that, and you have to have a workforce that's willing to do that. And I think if we engage the frontline people, that's how we're going to get our best bang for our buck. Asking the people who actually do the work, and that's what I do on a day-to-day basis. What's going to make your day better, and how are we going to get our patients through? And if you let them come up with the solutions, it's going to help us. So I think that we need to really engage the frontline staff, and then we really need to look at long-term recruitment and retention in the operating room is going to be a big issue in the next 5 years. It looks like the last study I read from the state that came from AORN was they're predicting about 20% of their OR nursing workforce is actually going to retire in the next 5 years. So if you look at 20% across a very large place, I would anticipate it's probably very similar in Canada. So I think that we really need to look at ways to either keep that workforce here, or we start recruiting and start retaining some of these newer people who are coming to our areas. Because if we don't, we're going to be 5 years from now in a worse disaster than we're in right now.
Thank you, Jen. Maureen, you get the pleasure of making the last comment.
Well, thanks for having me. And you know what, I agree with Sharon or Jen, who said about us doing work together. And I would really like to see our organizations meeting more regularly, and maybe with small groups working on different solutions to orthopedic problems, because some of the issues are short term. A lot of them are long term, and I think we could all work together and do some good work.
Yeah, I couldn't agree more. I have to say, I will say this out. I saved this comment to the last. When we first were bringing this group together of nurses and surgeons, we thought we would have a polarizing opposite views. But what I saw today was what I expected, which is typical in Canada, is a real synergy for people to work together to put the patients and families right in the center of it. And that's what I heard today. I'm humbled and honored to actually be co-moderating this session with Jeremy. So thank you all for your participation. As I say, this is just the beginning of, I think, what would be a great collaboration between our organizations and other like-minded people that want to come and think about innovative solutions. So I think our next webinar is after, as you suggested, Maureen, small group of our respective organizations work together in the back end, really discuss what innovations are currently happening, what could we work together, and then bring this back to our organizations again on the form of another discussion or webinar. So I'm very grateful for all of you for taking time off, your family time, your busy time to be here. And on behalf of all of our respective memberships and non-members that are here today listening to this webinar, a sincere thanks to all of our panelists for participating and sharing their wisdom. Have a great evening.